which will sort of, and the recognizing portion of it, which will attach to the lymphocyte. And we remove the genes which we don't want, those are replicating genes, etc., and the genes which it uses for assembly of itself. And we replace it instead with the gene of our interest. So this is schematically shown over here, down in the left panel at the bottom. It's got a variable region which can recognize, this is the mouse antibody, which can recognize the CD19 antigen in this case, which is, expressed on B cells. And then it has got a hinge domain and a transmembrane domain. The hinge domain attaches to the variable portion of the antibody. The transmembrane helps it to cross the membrane. So literally, that's what it means. Then it has got a co-stimulatory molecule, which sort of gives more energy to the CAR T cell. And then it has got an anchoring domain, which anchors it to the lymphocyte. So that the CD3, is expressed on all lymphocytes. So CD3 zeta is what helps it to anchor into the lymphocyte. If you go to the graphic in the center, you will find the various generations of CARs. In the first generation of CAR, there's only a variable portion outside and a hinge domain and a transmembrane domain, and the CD3, which is anchoring it to the lymphocyte. So these also should theoretically work, but they don't because these cells get exhausted very fast. So when they tried this, they found that it literally has no effect, clinical effect. So theoretically, it does do the job. So when they started attaching co-stimulatory molecules to the CAR construct, that's what we call a second generation CAR. This was like attaching a powerhouse or a turbo engine to the CAR. So this helps it to proliferate and to energize it, so to say, and gives it proliferative properties, which helps it to grow and do the job. You can also add two co-stimulatory domains. These are just the common ones. There's several more. And depending on that, it can become third generation or fourth generation CARs. You can do a lot more playing around with the construct once this basic engineering is possible, which we'll touch upon a little later, but not essential to our current talk. So once we give this cells back to the patient, it engages with the target, like let's say CD19 in this case, which is expressed on the B cells. And this stimulates the lymphocyte, so it proliferates. So the more the number of B cells it encounters, the more it proliferates. So it grows inside the body. So it becomes a living drug. So we call it a live drug. This engages, proliferates, and destroys the target. So it can grow to the extent that is required. So are we all clear now on what are CAR T cells and how they act?
Yes, sir.
Anybody, any questions, any doubts on this? Mansoor, you're okay, Crystal?
Yes, sir.
All right, okay. So let's go ahead then. So coming to the approved therapies, they are a lot now. In August 2017, the first one, Tisagen Leclucel, which is also called Chimeric brand name, that was FDA approved in the US in August 2017. Then came a host of other approvals for various indications. And now there have been two more. And now we are also getting approvals for gene therapies. So this was the Chimeric became the first gene therapy approved for human use, cell and gene therapy. And now we have got many more which have come into the place. But along with the approvals have come very exorbitant, price tags, close to $500,000 for Yescarta and Chimeric. So this is where we are today. So now with this background, let's go into a typical case of CAR T. What I've done is that I'm giving you only one case because it's a new topic. So I thought several cases might become more confusing. All the events which I'm describing in this case have actually occurred, but they have not occurred to the same patient. So, but what we have done is that I've sort of recreated the scenario to make a case which is based on actual events, but not all in the same patient. So with that background, let's proceed. The first patient is, this patient is an 11-year-old girl. She has had relapsed refractory DALL. She has underwent BMFM 90 induction. It was no response. I mean, she had 20-30% blast at the end of it. She underwent 3 more intensive chemotherapy cycles. At the end of each cycle, she would have 20-30% blast. She got referred to another center where she received again 2 lines of salvage chemotherapy with a similar minimal response. And finally, she got referred for the CAR T trial because it had opened at our center. So when she came, she had hemoglobin 9, WBC around 1,000, neutrophil counts around 240, lymphocyte count 750, and platelets 43,000. So as you are all well aware, this reflects some kind of pancytopenia, right?
Yes, sir.
Yeah. So, okay. So now questions for you. Is Christy there? Yeah. You would like to take this on? Who's Dr. Swati? Okay, yeah.
Yes, sir.
So, yeah. So when a cancer patient is identified for CAR T cell therapy, what is the course that they are going to go through, and what are we going to do step by step? If you have read, then you can let me know.
So first we'll know is the patient eligible for CAR T cell therapy. So first we should screen for eligibility. Then
Okay.
if the patient is eligible, then we can take him for this apheresis and then further CAR T cell therapy accordingly. And we can see and we can judge accordingly, like evaluation pre-CAR T cell, what was there, then in early CAR T cell, what are the changes, and late CAR T cell, what are the changes that we want to see.
Right, right. Wonderful. Okay, so what are the evaluations that we need to do to find out whether a patient is eligible for CAR T cells or not? Uh, Anybody else would like to try, or you'd only like to go? Go ahead.
Sir, clinical criteria, there are two criteria, clinical and lab criteria. In clinical
Okay.
criteria, we have to see for the presence of CD19 positive lymphoblast in the bone marrow or peripheral blood. Should be more than 5%.
More than 5%. Okay, okay. We'll come to that. Everybody agrees with this assessment? No? Akshata?
We should see what is the disease burden and what is the life expectancy of the patient, and is the clinically what is the patient like? Is it a relapsed patient or not? Clinical criteria are these, and then coming to lab criteria, we should see for baseline CD19 values, then CD3 levels, then peripheral blood and bone marrow evaluation for disease burden.
Wonderful. That's right. Yeah, that's more like it. So, and the last question, how do we plan the next step, which is apheresis? So once we've done these evaluations, are there certain criteria that we need going in to see whether the patient is fit for apheresis? See, remember, these patients are all relapse refractory. They have not responded to chemotherapy. That's why they come for CAR T. They got blasts in the bone marrow. They may have blasts in the peripheral blood. They got low counts, like you saw in this patient. So, how are you going to do the collection? So, are there some criteria?
Yes, so there are some criteria. For example, the age of eligibility is greater than 5 or less or equal to 65 years of age. Weight should be greater or equal to 15 kgs.
Patients are all relapse refractory. They have not responded to chemotherapy. That's why they come for CAR T. They got blasts in the bone marrow. They may have blasts in the peripheral blood. They got low counts, like you saw in this patient. So, how are you going to do the collection? So, are there some criteria?
Yes, so there are some criteria. For example, the age of eligibility is greater than 5 or less or equal to 65 years of age. Weight should be greater or equal to 15 kgs. And then we have to confirm that the disease is present and the disease status, whether it's a treatment failure or a relapsed case. Then we will also look at the performance status of the patient. So there are many scales for that according to age. And then we will also look at the organ function of the patient, like the absolute neutrophil count should be greater than 750 per microliter. Platelets should be at least 30,000. Bilirubin should be less or equal to 2 times the upper limit. LFT should be within normal limits.
Okay, somebody has prepared well. Yeah, thanks, Suman. That's very good. So we'll just, for the sake of everybody, we'll take everybody through this. The typical course of a CAR T patient is that first, we are screening them to see whether they are eligible for the therapy or not. Then, of course, in a trial, there's enrollment, but otherwise, if it's not a trial, you can take the consent of the patient and go ahead. Then we plan the apheresis, so that requires some steps. And then once we have done the apheresis, the cells are sent to the manufacturing facility to do the cell manufacture, which can take up to 2 to 3 weeks or sometimes longer. But now we can increasingly make it shorter also. Meanwhile, you have to keep the patient alive. That's the clinician's challenge. And so because the disease is anyway not responding, so it should not progress these 3 weeks. And we also don't want the patient to fall very sick during this period. So we don't want to give very intensive chemotherapy either. So once the CAR T cells are ready and the manufacturing facility like Dr. Rahul gives us green signal, then we take the patient in for lymphodepletion therapy and give the CAR T cell infusion, and then we just sit and watch. Okay. So the patient remains with us because it's a one-time therapy. De diya to de diya. After that, we sit and wait and monitor the patient for any complications. And then about a month later or 2 months later, 3 months later, we do the bone marrows to see how they have responded and follow up on flow cytometry. And then we do the long-term follow-up. So this is the typical course of a CAR T patient. And coming to the lab criteria, yes, since the target is CD19, we need to know whether the target is present in the patients, right? That is the most important thing. So now to find out whether the target is present or not, we look at the flow cytometry plots. What you are all aware of is like, CD19 is the target over here. And can you tell me what this plot is showing? The first plot, Mansoor, would you like to try?
CD19 is showing a positive expression.
CD20?
CD20 is negative.
Okay, so here you're finding that but more importantly than that, okay, then come to the second one. They're all showing CD19 positive. All the 3 plots are showing CD19 positive.
Some are negative, some are positive.
Is there any plot which is CD19 negative?
Yes,
Third one. Some of the cells are CD19 negative in the third
yes,
plot.
and second also.
Right.
Third one, yeah.
But
In
if I
second
was
also,
to ask,
third also, there is something.
yes, but if I was to just ask you that does this do these blasts express CD19, what would your answer be? And
yes.
if you
They do express.
yes, yeah. So they all expressing CD19. So in a normal flow cytometry report, they would all get reported as CD19 expression positive, right? And in fact, the third one would get reported as bright positive, isn't it? Right?
Yes.
But that's not what we are looking at over here. What we are interested in is whether all the blasts are showing CD19 or not. That is the key issue for us. Because if there are blasts which are not expressing CD19, even if it is bright, like in the right panel, or moderate to intense in the center one, it is irrelevant to us because there will be cells which are not expressing CD19, which will not be attacked by our CAR T, right? So for this reason, we have a screening step in which we see that unless all the cells, like in the left panel, more than 99, because you can never be 100%, some dots will fall outside this plot. But as long as almost more than 99% of the cells are showing CD19 positivity, we are comfortable. Once it reaches 8%, 5%, 6% of the cells are not expressing CD19 at all, these cells are not going to be attacked very well by our CD19 CAR. So this patient may not be eligible. So this is not a standard exclusion criteria in most trials because, it is also depends on limit of detection. So these cells may be showing up as CD19 negative, but the number of molecules on the surface may be lower. And that's why it may be showing up as CD19 negative, and it may not be necessarily that they don't express CD19 at all. But somewhere we have to draw the line. So we have drawn the line here. So this part is clear. Then what are the stages of monitoring of the patient? So we have a pre-CAR T evaluation. We have then, infusion and early post-CAR T evaluation. And then we have the late evaluation. So in the pre-evaluation, like somebody's already pointed out, Akshata, I think that, we check the CD3 counts because we have to see whether they're fit for apheresis or not. And of course, we're looking at the disease burden, etc., to decide when we can take apheresis and, optimal collection should be there. Then in the early post-CAR T phase, apart from the, biochemical and markers, etc., we are closely monitoring the cytokines because the major effect of these CAR T cells is when they destroy the antibody, the target cells, there are a release of a lot of cytokines into the circulation, which can cause cytokine storm. Yeah, and then after that, we are more interested in whether the B cells have disappeared or not. So we are monitoring for B cell aplasia, and we are looking whether the CAR Ts are persisting or not. So that we can come to know if the patient is doing well or not. So these are the stages that we will be monitoring. So next question is when to take up for apheresis. And I think Roman answered that very well. So I will not ask you now. I will just take you through it. This is a standard, what do you call, reference for how to decide when to take up patients for apheresis. Of course, do the routine evaluations and the viral markers, etc. But basically, we are looking at whether the total WBC count and the absolute lymphocyte count. Here, remember, we are not interested in the neutrophil count. We are collecting lymphocytes. We are interested in the lymphocyte count. So you can go as low as lymphocyte counts of 150. More than 1,000 is ideal, but the collection has to become higher and higher. So we have to go to 4 times the total blood volume. Apheresis collection has to be done. All of you are familiar with apheresis, no? I am. Yeah. Okay. Right. So then, but if it is less than 1, or if ALC is less than 150, then, or there's a lot of circulating blasts in the peripheral blood, then we have to delay the collection. So this is the way we go about it. So then we give some chemotherapy to the patient, try to reduce the blast so that the normal cells can grow. And this is a very important question. So, it is not just that we need enough cells to collect, because the number of cells which we need to start is not that much. We just need about, even with 10, 20, 40, 50 million cells, 100 million cells, we can start. And a typical apheresis collection gives us much more than that. But even then, this is important because it has been seen that the CD3 percentage in the yield in the bag, pre-apheresis, lymphocyte count, and in what you get in the bag, that correlates with the outcome. So the better it is, the more likely you are going to get a good outcome. And this is a reference of our own work. Publication is still not there, but this was presented in a meeting in which we showed that it was possible to do good collections with absolute lymphocyte counts of median of around 878 and as low as 215 cells, lymphocytes per microliter. We were able to proceed, and we did not have any manufacturing failure in any patient as a result of this. So this is pre-harvest CD3 count, which is to illustrate the same principle. And I've just gone over that. So here, this is how you calculate the absolute CD3 count in these plots. And in this case, it is working out to 710 cells per microliter. So we were able to proceed with the apheresis. Right. And this is the harvest, which gives us we started with 710 cells per microliter in the patient, and post collection in the harvest, we have a concentration of 7,000, so nearly 1,000, nearly 100-fold, 10-fold expansion in the collection. So that gives us sufficient cells. So now we can proceed with the patient, where our patient is. So now the patient is being evaluated. We find when we do the bone marrow that the patient is BCR-ABL positive. Stunningly, this has been missed in 2 different centers that she had been seen earlier. And the reason for that, what could be the reason for that? How could such a simple basic investigation be missed? It's something to think about. Okay, that's because the basic investigation was missed. The cytogenetics were not done. Straight away, NGS panel was done, and that too only for it was not done for translocation. It was just done for mutation. So it was not picked up in that, and that's why the basic So this is just a lesson learned. Please always do the cytogenetics in any workup of an ALL. Don't go for panels without doing cytogenetics. So the disease starts rapidly progressing. So we put her on metronomic chemotherapy, and for the first time, she starts getting a tyrosine kinase inhibitor. We get some amount of control, and then again it progresses. And this time we find that she's got a T315Y mutation. What is the T315Y mutation? Akshata? I'm sorry, Igita, I have not asked any question at all. Dr. Igita? What does the T315Y mutation imply?
Even Shreya is there. Shreya
is also there? Okay.
Yeah.
Right. Shreya? What is T315Y mutation? Okay, anyone?
Something related to
Sir, can I answer?
Yes,
Sir,
of course, Mansoor, go ahead.
T315 mutation is a tyrosine kinase mutation.
Uh-huh.
We use the mutation to see sensitivity to tyrosine kinase inhibitor. In this case, I think this mutation, we have to use ponatinib.
Correct. So this T315 mutation is resistant to almost all tyrosine kinases, TKIs that are known, except for ponatinib and some others which are very expensive and mostly not available.
This
So
was
this
Dr.
is
Ghazi. Gaurav,
Yes, sir.
this was Dr.
Yes,
Ghazi
sir.
Islam. This was Dr. Ghazi.
This is Dr. Ghazi, no? Not Mansoor. Yeah, I got that. Yeah. So by the time the panel opens on my video, it has changed. Right. So our aim, like from the clinical side, is to keep the patient alive and in good condition. So we use chemotherapies, but this is not really for all of you. But what we just to bring you to speed, basically our aim is to keep the patient alive and in good condition. So we don't want to give something which will be too toxic. At the same time, we don't want to give something so light that it will not control the disease only, because these are already relapsed refractory patients. They are chemo resistant. So our aim is to just sort of control the disease and keep it under control. Remember, unlike transplant, we do not need the patient to be in remission. And to go for a bone marrow transplant, patient needs to be in remission. In case of CAR-T, we do not need the patient to be in remission. So we just need the patient to be in good condition. So going on with the patient undergoes a successful apheresis, but unfortunately, because of the low counts, develops sepsis. And takes 2 weeks to recover from the sepsis and is shifted into the BMT ward, but that day has fever and cough, and we do a biofire and find that it is COVID. So the patient is moved out into the COVID ward, develops full-blown COVID, and just before the day before we develop COVID with the bone marrow we are done, we've seen that it's already 50% blast. So patient receives the antibody cocktail, remdesivir, supportive care, but by this time 3 to 4 weeks have gone and there is no chemo. So the patient whom we were trying to keep in good condition has now become in very bad condition. Fortunately for us, the patient started improving, and all the risks were anyway explained. And then from the COVID ward, we were able to transfer the patient back and continue with the CAR-T. So we'll come back to that later. So the question is, does anybody have any idea how CAR-T cells are manufactured and what are the tests required that we need to know that the CAR-T product is safe and can be used for a patient? Dr. Ghazi, you seem to have read about CAR-T well. Yeah. So,
No, sir, I have no idea about these things.
okay. So anyone else would like to try?
So we take the T cells from the patients, and then we use a viral vector to insert the CAR into the T cells, and then they proliferate in vitro. And then after that, we do some safety tests, and then it goes back into the patient. So we'll do tests for safety, that is, if it is clear of any microorganisms. So we'll do gram staining and mycoplasma tests and any active viral tests. We'll check for purity of the sample. So we'll do the percentage of CD3 positive T cells and the percentage of CAR T cells. And then we can also do tests for potency, that is in vitro cytotoxic T lymphocytes or interferon gamma scan.
Right. This is very nice, very well done. So I think you're really well prepared. That's great. So I'm a bit surprised because I had already explained to you how CAR-T cells are manufactured. So, but I'm very glad. Sorry, sir, you were saying something?
This is
Dr. Dajal, so you...
Yeah, this is Dr. Roma.
This is Roman, I think. Yeah. So she answered very well in the previous question also. So, yeah, that's great. So this is just what we told you about in the manufacturing process. So in the manufacturing process, you do what's in the lab, but you have to do it in a manufacturing facility. So just like it's like the big pharma companies and their factories. So that way, like Dr. Rahul Purwar has got a big company which is called Immuno-effector and which can do all this manufacturing in an industrial scale. So here what we do is that, this is the vector which you have, which is what we designed. So that's over here. So you have inputs vector and you have inputs which are the cells from the patient. Then the cells undergo a process which we have already described. There's some selection is there. Then they are activated. Then they are transduced to this vector, and then they are expanded. And then once we got the desired dose, then we start the processing for giving. So you remove the beads and then you subject them to a battery of tests. If you can't give fresh, then you cryopreserve it and formulate it and put it into a bag which will be ready for the infusion after thawing. So this becomes the output. So normally when we say CAR T cells, this is what we mean. This ready finished product is what we call CAR T cells. But very often when we are talking about CAR T, we are actually talking only about the vector. So when we say this is our CAR, what we mean is this is our vector. So it's a bit confusing at times. So this is just to make it clear to you in normal pharmacological terms. The vector that is designed is called the drug substance in pharmacological terms. The manufacturing is called drug process. And the CAR T cells, which has finally come out, the product, which is the T cells with the vector and expressing the antibody on the surface, is the product. So the tests are done on the product. Okay. So this is what a typical certificate of analysis looks like. And Roma, I think, very nicely said, we are looking at different things in it. We are looking at safety, we are looking at the identity, and we are looking at its efficacy. So these are the various battery of tests which are done. And this is a sample one. So you can see what is RCL. Anybody knows what is RCL? RCL stands for replication competent lentivirus. So we have used a lentiviral vector, which is a type of retrovirus. So RCL means that is there any viral particles which are capable of replicating? That's what it means. So you do this by a PCR test and you find that it is negative. Sterility has been tested by microbiology, so it's negative. Then we have to check for viral contamination. In-process contamination may have occurred from the workers. So that, we do a battery of respiratory and meningeal viruses, which might reside in the nose or in the respiratory tract or on the skin. And we normally do it by biofile, but we can also do it by multiplex PCR, which is customized, and we find it is negative. Why do we test for mycoplasma? Anyone? Why do we test for mycoplasma?
It can't be detected on gram stain because it doesn't have a cell wall.
Okay, fine. But why do we need to specifically test for mycoplasma? No, that's very good. Yeah, it will not be picked up in routine. But why is it specifically do we need to check for it? Mansoor, you want to try?
Sir, maybe because of the genomic, no, sir.
Okay. So mycoplasma has a propensity to grow in cells, in cell cultures. So wherever you're doing cell culture, mycoplasma is an organism which is likely to grow over there. And as you rightly pointed out, it may not be picked up on the routine test, so it has to be tested separately. So wherever you go, the regulator, whether you're in the US or in the Europe or in India, the regulator always requires you to test for mycoplasma separately. It's a frequent contaminant of cell culture. And then endotoxin. So that is a test. And the rest are, of course, related to the identity of the CAR T cells, which we just need to broadly understand. We'll not go into specifics. And this is, of course, the viability. So it needs to be about 70%, and in this case, it is 97%. So we have a very good product over here, which is sort of ready to go. Then we have to calculate the dose. And this is more a clinical issue, but I have just given the sample over there for educational purpose, how we go about calculating the dose. We know the cells number of dose we have to give. Let's say we have to give 5 million per kg CAR T cell. The weight is 50 kgs, the patients. So we know that the dose has got to be 50 kgs into 5 million. So that becomes 250 million CAR T cells we need to give. In this case, we found the transcription efficiency was 44.53%. So, and the viability is 97%. So the cells in the bag, let's say they were 1 billion cells were there in the bag, and it was a 30 ml bag. Then we take a QC vial along with the bag. There's a separate QC vial which is also frozen along with the bag. So first we only take out that vial. We don't thaw the bag. We only thaw the vial. Once we thaw the vial, we check the viability again, generally by bedside. Trypanoside is available immediately, and we also send it back up for flow cytometry, but we can check by trypanoside on the bedside. And let's say this time it comes 95%. So then we know that 1 ml of the bag contains so many cells, number of cells multiplied by transduction efficiency multiplied by viability, and divided by volume, which is 30 ml, will give you the number of cells per ml. And then for the desired dose, we can divide 250, which is the desired dose, by 14.1 million, which is there in each ml. Then we know that the dose which we have to give is 17.7 ml or 18 ml for the bag. If anybody's math is weak, you can have this in front of you. This is how the dose calculation is done, but I think it's a simple calculation if you get the flow of it. So let's get back to our patient now. Patient has undergone successful apheresis and product manufacture. Pre-CAR T infusion, we don't know the blast, but because we knew it was 50% a few weeks ago, by now it might have become much more. We don't know. We go ahead and give the infusion. And on day 5, the patient develops a low-grade fever, but we give paracetamol, it responds. But of course, the counts are also low. You all know about febrile neutropenia. I do have to explain febrile neutropenia here. Fever with low counts, when patients undergoing leukemia management or chemotherapy, when they have low counts, low neutrophil counts below 750 and 500, we call them, and if they develop fever, we call it febrile neutropenia. We have to presume that this may be sepsis, and we start them on broad-spectrum antibiotics. So, in this case, the broad-spectrum antibiotics were started. So, the low counts are low, and fever is there. So, this may be infection. This may be, what else?
Cytokine release syndrome.
Cytokine release syndrome.
Correct. It might be cytokine release syndrome. It may be sepsis. How can we make out the difference between them?
By doing a blood culture.
Blood culture we can do, very good, but it will take about 2 days minimum for a provisional report and 5 days for a final report. So till then, we can't wait. Other tests which we can do?
Empiric antibiotic therapy.
Go on. Yeah.
Empirical antibiotic therapy.
It's on your screen. We have done CRP. Okay, C-reactive protein. This level, is it low, high, moderate? Anyone? Is this CRP low, normal,
CRP
high?
low. CRP low.
I'm sorry, I'm not giving you
levels.
Yeah, sorry. Yes, it's above normal, but it's very low. So definitely it's not sepsis. So we do a cytokine panel because it may be CRS. In once patient has been given CAR T, we presume it is CRS until it is ruled out. It is the other way around. So we send a cytokine panel, and in the cytokine panel, we find that anything in the cytokine panel? Anybody notice anything?
So level of interleukin-6 is increased.
Good. Any others?
Level of interleukin-6 is increased. So accordingly.
Yes. Very good. IL-6 is definitely increased. Any others which are increased?
IL-2 is also increased.
IL-10 is also increased.
Did anyone check the normal values of these cytokines? IL-10 is also increased, yes. And any other increase? But these are all mild increases. They're not much. They're nothing spectacular here. Okay. And interferon gamma is also slightly increased. Okay. We continue the antibiotics, but by blood culture 2 days later, still there is no growth, which is sort of expected. We know this is CRS only. Okay. So can anybody tell me what is cytokine release syndrome and what are the key cytokines involved in CRS?
It is.
Ismail.
Yes.
Yeah, you continue.
So when our immune cells react excessively either to the infections or the immunotherapy we give, that time the more of cytokines are released, and majorly cytokine 2, interferon gamma, apart from then interleukin 4, 5, 13, these and all, when they increase, we can look for cytokine release syndrome after our CAR T.
Wonderful. Very good. Yeah, right. Okay. And what is the characteristic one which is elevated in cytokine release syndrome due to immunotherapy?
1 and 6, sir.
Six,
1 and 6.
interleukin 6
Okay.
based.
Yeah, mostly 6 and one also there's more in neurotoxicity. Okay. But the features are the same. Cytokines are elevated in sepsis also. Cytokines are elevated in CRS also. And both are going to present with fever, and because the counts are low, how do you distinguish? Is there any way of differentiating between the sepsis and other inflammatory complications? You all know about HLH and macrophage activation syndrome. So there also all the
Look
fever
for
will be
the.
there, and yeah.
So we'll be looking for other markers, just as in HLH and mass, we'll be having ferritin high in transfer. That other markers we can look for. Are there any organomegaly or something?
Yes, so you're right, but ferritin can be elevated in CRS also. Okay, ferritin can be elevated in sepsis also. It's an inflammatory marker. So you're right, but that is not the whole answer. Anybody? Can you elaborate on it?
So in HLH, there will be hypertriglyceridemia and hypofibrinogenemia. But in sepsis, there might be complication of DIC in which.
Yes, but correlation abnormalities can be there in HLH also. So you're all saying the right thing, but what I'm trying to tell you over here is that no one marker gives you the difference. So you have to see the pattern. In CRS, you will get a different pattern. In sepsis, you will get a different pattern. So it is not just this one will be elevated or that one will be elevated. These will be elevated, but the others will not be elevated. So like that, the different patterns you get between the two, which tells you which one is acting. So just to revise, what are the cytokines? So, these are the different T cell affected subgroups. And depending upon the subgroup, they are known to secrete different kinds of cytokines, ranging from the, IL-2 and interferon gamma come from your Th1 cells. Interferon gamma also comes from your cytotoxic T lymphocytes, which are activated ones. Okay. Interleukin 4, 5, 13, they come from your Th2 cells. They act more towards the eosinophils and basophils, not much involved over here. 9 and 10 are the ones which are recruiting the mast cells. So when IL-10 is in this thing, we know that here it's probably more likely to be going towards sepsis. So this is how we see which the cytokines have been secreted, and that helps us to identify which ones might be the ones which are involved and what process is involved. And this is just there for for all of you to remember. Nobody can remember all this by heart. You're not supposed to, but it is important to know these cytokines and what are their actions and which one is acting in what. Because now more and more when we are dealing with these complicated situations and immunotherapy, these panels are becoming more and more important, and we have to know what they do. So this is again going through the entire list, which tells you, and it is and the last is your plasma proteins, which is CRP, complement, and ferritin, which are the ones which will also help you to decide whether it is HLH or not, or sepsis or not. So these are there for just for your reference purpose, not really for remembering. So coming back to the pathophysiology of CRS, so you've already explained it, very well. Basically, what is happening over here is that once the tumor cells is being attacked by the CAR T cells and it's being broken down, then it is presenting to the CAR T cells in different ways. The CAR T cells are getting activated. They are secreting GM-CSF, interferon gamma, and tumor necrosis factor and catecholamines. This leads to macrophage activation. And also macrophages then in turn release the IL-6 and IL-1, which are most biggest drivers for cytokine release syndrome and neurotoxicity. So, why am I getting an echo? Okay. So, these also, what you call the chemokines also recruit the circulating monocytes, which puts us into a feedback kind of mechanism. And that leads to vascular leakage, hypertension, which are the classical features of site CR. As you are aware, these are also the classical features of sepsis. It's always difficult to make out which one is happening, and that's why we rely heavily on the cytokine markers and the cytokine profile. So in this patient, the day 7, the fever is persisting. It is low grade, intermittent, hemodynamically stable. And any changes in the cytokine profile that we are seeing now? Akshata?
It is still elevated only.
It's elevated. So it is more or less the same, but only
Yes.
everything is gone slightly up. Okay. Huh? But apart from that, it is more or less the same. So we know that this is CRS only, which is cooking. Cultures are still negative, CRPs are low. So the panel is the one which is giving us the indication that this is still CRS only. So this brings us to the biggest problem which a clinician has. The treatment for CRS is the IL-6 inhibitor, and there's a drug is called tocilizumab, which is an IL-6 inhibitor, which is well known. And you're sitting with a patient who's having fever every day, and it is CRS, but it is only grade 1. If you can give tocilizumab, the fever will go away. But whether this is the right stage to give it or not is the biggest question. So somebody who's in the CAR-T space, or Dr. Rahul Banerjee, he's US based. He put this slide, which I found really, really nice. He said, based on the Shakespeare play, to be or not to be, that is the question. Is to see or not to see? That is the question. Whether it is nobler in the mind to suffer the slings and arrows of outstanding T cells or to take arms against the sea of cytokines. So this is the dilemma that the clinician faces. But the only way we can overcome this dilemma is by the cytokine panel, which we get from the lab, and that is from all of you. That is what helps us to overcome this dilemma. So this is how CRS is graded. It's a clinical grading. It's got nothing to do with the lab at all. It is a completely clinical grading. Unless there is hypotension or hypoxia, it remains grade 1. Moment there is hypotension, we call it grade 2. Or if it requires even a little bit of oxygen, it becomes grade 2. If it requires vasopressors, then it becomes grade 3. If it requires anything more than low flow oxygen, it becomes grade 3. And if patient goes on ventilator or requires multiple pressors, it becomes grade 4. Grade 5, of course, means the patient is no more. So this is how we grade CRS. Okay. So it's a completely clinical grading. So we have to just observe the patient clinically carefully, and we have to depend upon the cytokine panels. So now on day 11, the patient fever persists, and now this patient has hypotension requiring a fluid bolus. So going by our grading, this is now clearly grade 2, isn't it? Huh? And 1 pressor was required, and then we do the cytokine profile IL-6 stat in the lab, and this is now 4,300 picograms per ml. So is this normal or high?
Hi.
Can we do better than that? This is very high. Okay. Huh? So this is what can happen in CRS. You can see sky high values. Okay. So now we don't have that dilemma at all, clinician dilemma. The patient gets tocilizumab. But also by the next day, he developed dysphagia, motor weakness, and deteriorating handwriting. So what is happening now?
Neurotoxicity.
Patient has developed neurotoxicity.
Excellent. Patient has developed neurotoxicity now. Okay. Huh? So, but what happened to the fever? The fever resolved very rapidly. Within few hours of giving the tocilizumab, fever, hypotension, everything got corrected. But by next day, we are seeing dysphagia and motor weakness and neurotoxicity. So, what is ICANS? Can anybody tell me what is the full form of ICANS?
Immune-effector
Associated
syndrome.
neurotoxicity. So immune-effector.
Roma, you were trying to go ahead. Yeah.
Immune-effector cell-associated neurotoxicity syndrome.
Excellent, excellent. So that's what's ICANS. Okay, huh? And what is the grading? Anybody? How is it graded? And it's a clinical grading.
1 to 4 again.
So
Depending on clinic.
yeah, go ahead. Who was trying that? Matsu? Yeah, go ahead.
So it's again a clinical grading from grade 1 to grade 4, depending upon the patient is having encephalopathy, seizures, and tremor, dysphagia.
Yes, that's right. It's a clinical pathological grading. So it's a clinical grading. You don't need to know it by heart. You just need to know that this is a universally accepted grading now. And the best way of monitoring it on the bedside is to look at the handwriting. So the kids, we ask them to keep drawing something, and the older children, or the adults, we ask them to write something. So morning, evening, when we go to the bedside, we see the handwriting, and you can see classically over here how this patient. This is an example of what happened to the handwriting. and this is by day 6 when it became normalized after the immunotoxicity kind of resolved. So this is how effective of way it is of monitoring. Of course, the severe features are very severe and they don't need to be they can't be confused. So this shows you the pathophysiology of CRS and ICANS and how CNS is. I will go over to the next slide. And this shows you how the CRS and ICANS differ in when they present. Normally, CRS presents early, whereas ICANS starts presenting in the 2nd to 3rd week. But there's a period in between where they can overlap. This is exactly what happened in our patient. Day 11, peak CRS, and day 12 also ICANS, so somewhere over here. And this correlates with CAR-T. The CAR-T which we are given starts expanding in vivo inside the patient. We already saw that, we had discussed that in the beginning. And as the CAR-T keeps expanding, early in the expansion you get CRS, late in the expansion with peak infection you can get CNS toxicity. And the cytokines which are responsible for both are different. So these are the cytokines which are operative early, and these are the cytokines which are operative towards the middle stage. So this is how the panels of cytokines change over time, and this is the difference in the toxicities that we see. But because of knowing exactly which cytokine is causing the toxicity, we have a way to intervene. So with each one of these cytokines, we have an inhibitor which is available. The CAR-T itself can be inhibited by tyrosine kinase inhibitors like dasatinib. T1 nucleus TNF can be inhibited by specific inhibitors, adalimumab and etanercept. Catecholamines can be inhibited by metedosine. GM-CSF can be inhibited by lenalidomide. IL-6 we already know can be inhibited by tocilizumab, and IL-1 can be inhibited by anakinra. So for each one, we have specific treatment available. And that is why it is so important to know which one is elevated and what their roles are in these diseases. So next is to the last part now we're coming. How do we detect the CAR T cells in vivo and how do we assess the response? Anybody? Roma, you're the one who's coming out with the answers today.
So by flow cytometry.
Okay, what's happened over here? Yeah, by flow cytometry. What do you do?
I did not exactly understand this part of the presentation.
Okay. So I guess this is a bit complicated, but you all know the basics of flow cytometry and lymphocyte subset analysis, and also how to detect a diagnosis of ALL and MRD, because these classes have been done before. So are you all familiar with that? Not with CAR-T, just with normal flow cytometry for ALL and lymphocytes subsets. Somebody give me an answer. Yes, no? Akshata, are you all not familiar with normal flow cytometry?
Yes, sir.
Huh?
Yes, sir, we are.
Okay, because those have been held before. I know Prashant and Gaurav Chatterjee have taken some very excellent ones for you before. So that's why, yeah. So, okay. So then, since your background knowledge is likely to be low on this, I'll just go ahead and explain it from my side. Okay, yeah. So first is how do we detect CAR-T? One is that we have the CAR-T construct. Okay, so if we know the SCFE domain specifically, we can have a specific antibody to that and just tag it to the flow cytometer, or you could detect it by PCR. So those are the two ways that we can detect it. But if you want to do by flow cytometry, you can either have a specific antibody to your specific domain, or you can use protein L based, or it could be the antigen based, which is what I just said. So if you know the antigen, you can have the specific antibody to it, or you can just do it protein L based. And of course, anti-FMC3, that's a murine antibody, is a well-known one. So that's got a standard antibody. So you can have a flow cytometry tag antibody to that and detect it directly with that. So here Prashant is already here in the meeting. So since we have taken a lot of time to reach this part, I will leave it to him to explain if he wants to at the end of this. how we detect the CAR T percentage based on protein L. And this is showing you how CD3 CAR T plus like in this, like protein based on protein L, it's around 7.9% in the circulation. And then we monitor it over time. So, this is day 3, day 5, it starts appearing in circulation. And then generally by day 9, second week, we see the peak expansion. By the third week, it starts declining. But in the patients who are alive and responding, even now 180, what we are reaching 1 year now, day 360 now, we are finding that the CAR T cells continue to persist in the patient in the circulation. So coming back to our patient, the fever hypertension resolves. So steroids are started for neurotoxicity. That also recovers in 2 weeks. Low blood counts persist, but by the 4th week, they start recovering. And then when we do the bone marrow on day 30, it shows that patient is in remission. MRD is technically negative, but a low level 0.002% is still detectable. And what we are seeing is CD19 negative. So what happened over here? Why do they become CD19 negative? Anybody care to explain?
CD19 was targeted by CAR T cells, so we need to see.
Yeah. So CD19 was targeted. So CD19. So there are two things.
If there is CD19 negative cells, we can assume that there is no blast.
All right, but there are CD19 negative blasts are present. We said that 0.002% blasts were present. Okay. So you need to do extended markers because now you are, when you're doing the MRD, you are trying to look for B cell MRD, obviously. But now you cannot depend upon CD19 because CD19 has been knocked out or should have been knocked out. So you need an extended panel which needs to cover for that. I think that might be beyond the scope right now, but just let you know that this is the panel which Dr. Prashant is using in our lab. And this is to explain how you can get CD19 negative relapse. So in a tumor, we knew that we checked in the beginning and we showed you that, if more than 99% of the cells are CD19 positive, then it's fine, fair enough. But if at least 1 in 100 cells may be CD19 negative or more than that, then when the CD19 targeted therapy is used, all your CD19 positive cells are destroyed. But the CD19 negative cells remain untouched. And now these are blasts which are fully capable of proliferating. So they start proliferating rapidly and cause a full-blown CD19 negative relapse. So these are blasts which are not expressing CD19 and now they are the cause of the relapse. This is one way it can occur. The other way it can occur is that the blasts are also living cells. And when the living cell is being hammered because it is expressing CD19 on the surface, what it does is it stops expressing CD19 on the surface. So this is just to show you what can happen. This is the full-length CD19 which you're seeing in the left panel. And what happens is that if it is being sustainedly, the CD19 is being attacked, you get isoforms which are not the full length, and therefore they stop expressing on the surface or they become unanchored, and therefore they are no longer being expressed on the surface. So it sort of internalizes the CD19. It is something like because it is wearing a hat, the hat is being, it's getting hit. So it stops wearing a hat. It's just like that. So this is what the cells do. They adapt and they stop expressing CD19. So the CD19 is still there. It is just not being expressed on the surface anymore. So these are the two ways that you can get CD19 negative relapse. So now I have finished with my presentation and it is your turn to ask me questions or if there are any, and I'll be happy to take them.
Maybe Gaurav, can we invite our chairpersons for their comments?
Yes, sir. Absolutely. Please. Should I stop sharing the screen?
Yeah, then questions can come by students also. So we have Dr. Rahul with us, Dr. Rahul and Dr. Prashant. Rahul and Prashant, could you please switch on your videos if